Right. Good morning and welcome to the Hamilton Health Sciences Department of Medicine grand round for this morning. Our speaker is Dr. Mona Sidhu. Dr. Sidhu is a geriatrician practicing at Hamilton Health Sciences and an assistant professor in the Division of Geriatrics at the Department of Medicine at McMaster. She completed her internal medicine training at North Carolina, the Division of UNC Chapel Hill, and completed her geriatric medicine fellowship at McMaster University, followed by a geriatric nephrology fellowship at U of T. She then went on to complete a master's in health care administration at McMaster University. In addition to some interest in clinical administration, she has interest in pain management and have experience with cannabinoid use primarily in the form of CBD to treat pain in seniors. And it's been exciting to get Dr. Sidhu today to talk to us about the evolving use of cannabis in the older adult. Mona, please go ahead.
Good morning, everybody, and thank you for having me talk about cannabis. It's definitely an evolving topic. So we will be going through a case study as well as some evidence or lack of, as well as going through, what cannabis actually is and how it works. So we are privileged to provide care on the lands that the Indigenous peoples have called home for thousands of years. I don't have anything to disclose. And I always start off with a couple of polling questions for the audience. So for those, you can either put it in the chat or you can just, answer it to yourselves. The first question is what strain or variety of cannabis do you think is most helpful for pain management? Is it CBD predominant, THC predominant, or a hybrid where there are equal components of THC and CBD? And by the end of the presentation, we'll have a better idea of, which strain definitely can help with pain management. The second question is the most recent current evidence suggests that cannabinoids is a second line agent for management of chronic non-cancer pain. True or false? At the end of this presentation, you'll definitely become familiar with the basics of cannabis preparations, how they are consumed. We'll go through some of the evidence, not only for pain management, but various other geriatric syndromes, and as well as identify potential risks of cannabis in the older adult. So what is cannabis and how does it work? It's a plant and it has several different compounds, 85 of which act on cannabinoid receptors. These receptors are in our bodies. They make up the endocannabinoid system, which is very similar to the neurotransmitter system, largely distributed in the brain and the body. And these receptors are known as CB1 and CB2. There are also phytocannabinoids that are found in THC and CBD. So strains of cannabis can be differentiated by the actual plant itself, and you will see indica versus sativa, its chemical breakdown where you will see terms like CBD, CBN, THC, and there's several other chemical breakdown terms that are coming out now, but the most commonly known in research are CBD and THC. And then we have terpene profile, where these are organic compounds that really give the plant its flavor and odor, but may have some therapeutic value, although they're less studied for sure. So when we look at the subspecies of the plant, the indica plant is always a shorter plant and has more of a sedating effect. And the sativa plant is more narrow and has a more stimulating effect. Keep in mind that indica and sativa don't necessarily mean one has more CBD versus THC. And so it's important to know that it's a subspecies of the plant that may have these extra properties, but doesn't necessarily explain the chemical breakdown. So THC, or tetrahydrocannabinol, is the psychoactive chemical of cannabis, but it does have some potential therapeutic benefits, including it being an antiemetic. And so nabilone, which is a synthetic isomer of THC was traditionally used as a antiemetic for chemotherapy. It can act as an antispasmodic, an analgesic, as well as an appetite stimulant as well. But we must remember that it does have psychoactive effects. CBD, however, doesn't necessarily have these psychoactive effects. However, its mechanism is unclear as it has little binding affinity to the receptors. Its therapeutic potential, however, is vast. It can act as an anti-inflammatory, an anti-epileptic, an anxiolytic, as well as an antipsychotic. So the analogy I like to use to explain to patients on how the effects of cannabis is probably a lock and key mechanism. So if you picture the lock being the receptor, so the CB1 receptor, and then the THC being the key. The key initially comes in, so THC comes into our body, it unlocks the receptor and exerts its effect. But we don't have the same mechanism of action for CBD. So sometimes that can explain why CBD may not be as effective because it may not be binding to those receptors that I mentioned earlier. So CBD definitely has its advantages in the fact that its lack of psychoactivity and therefore can be administered in higher doses and on a more chronic basis. It's often better tolerated than THC products because of the lack of psychoactivity. Its disadvantages is that because we are not as clear of the mechanism of action, it may have low bioavailability, low solubility leading to incomplete absorption, a low affinity to the CB1 and CB2 receptors. It has known medication interactions, which I will discuss later. And then you may need higher doses for efficacy, and then higher doses can result in more adverse effects. This table here basically outlines the therapeutic potential. And as you can see here, CBD certainly does have more potentially therapeutic benefits compared to THC. But it's important to understand that THC can be used in combination with CBD for additional therapeutic benefits in some cases. So the terpenes, as I mentioned, these are organic compounds that give the plant its natural odor and flavor. Some of the most common compounds in cannabis include myrcene, limonene, D-linolol, and beta-caryophyllene. These terpenes are also found in things like hops and lemongrass and lavender. And so you'll see similar properties in these kinds of essential oils, especially with lavender being a natural sleep aid, more anxiolytic. So cannabis also has these types of terpenes that can potentially give these additional anti-inflammatory and analgesic effects. So the entourage effect is essentially the combination of CBD, THC, as well as the other chemical compounds of the plant, the flavonoids, which is the plant properties itself, as well as the terpene profile, has a more synergistic effect in exerting its therapeutic potential compared to CBD alone or THC alone. And so there is a theory that the plant-based cannabis is more effective than something like nabilone because you're essentially having the combination of several different cannabinoid products as well as the terpenes and the flavonoids. So routes of administration. So when cannabis was first legalized, really, and even before being used for medicinal purposes, really the only form was inhalation through smoking and vaporizing. And then after legalization, we certainly saw more preparations come out. So initially it was the oil. The edible goods has always been out, but it's not as favorable just because we don't know how to guide dosing, and you don't know how much you're actually ingesting when you're taking an edible good. So the oil came, and then after the oil came the capsule, and now there's the spray, and then there's also topical ointments as well. The main difference between inhalation and ingestion is like the time of onset. So those that want like more immediate effects, especially if they have breakthrough pain, are looking towards inhaled products, although it's not recommended. And then for longer onset, but has a longer duration as well, we look into products like the capsules and the oils. The spray is in between the inhalation and ingestion in terms of the onset. It has a shorter onset. Topical also doesn't have, it's more of a local effect without having that necessarily that systemic effect. So when cannabis oils are started, they're generally started at very low doses. They're placed anywhere between 0.1 and 0.2, placed directly on the tongue or in a fatty substance. The reason why fatty or a high protein substance is suggested is because that it can help absorption. It's very lipid rich and likes to bind with other foods that are also similar. So there is a theory that it can the absorption is better when it's mixed in food or taken directly after eating. Recommend the initial use to be used in the evening, and that's only because you don't know what the potential side effects would be. And so if there is an effect if there is a side effect that it may cause drowsiness, whether that is THC or CBD or a hybrid, then you want to be mindful of the time that is first administered. When you're increasing the dose, you want to increase very slowly and gradually on a scheduled basis. So when you obtain the product, whether it's from the Ontario Cannabis Store, from the local dispensary, or from a licensed producer, sometimes they will be labeled as such where you'll see the exact, so you'll always see the exact THC to CBD breakdown, which is mandated by Health Canada. But then there's additional information like the terpene profile, and that can just basically tell you which type of terpene may be there, and that in this case, this CBD oil would be more of an anti-inflammatory type of oil because it has more beta caryophyllene. The capsules are essentially, or the soft gels are essentially the oil that is just put in, that is formatted into a capsule or a soft gel form. It's comparable to the oil in terms of its concentration. It can be expensive just because you may need more than one capsule per day. And so often patients are, taking anywhere between 2 to 3 soft gels per day. And if you're using multiples, it can be significantly more expensive than using the oil itself. It just depends on where you're obtaining these soft gels. The benefits of the oil is that you can start with lower doses and you can guide the dosing. You can mix the oil. So in like the nursing home population where there's patients that have swallowing difficulties, you can definitely consider the oil. The capsules is certainly more convenient, can be, and also can be more administered more readily just because there's a way of measuring how much product is left over. The spray, so we have nabiximols, which is actually approved, and that spray is actually a combination of CBD and THC. But the plant-based spray has combinations of the various of CBD and THC. One spray usually equates to 0.1 milliliters. Its action of it is anywhere between a few minutes to half an hour. Its duration of action is less than the oil, but indications are similar to the inhaled form, such as panic attacks, breakthrough pain, muscle spasms, and to help with sleep. Topical, you apply it to the affected area as needed. It does not penetrate systemically. It's indicated for localized pain, and there is anecdotal patient experiences that report effective pain relief for osteoarthritis. To be honest, I don't know if a lot of this anecdotal patient experiences is somewhat placebo related. However, in my experience over the last, I would say 6 years or so, there are, considered a significant number of patients that are reporting that they do have some pain relief with the topical use. So now we're going to go through some of the most recent evidence. So the most recent trials from 2021, there's one from early 2021, and then there was one later in September. And what we're finding is that the more recent systematic reviews with pain control is actually suggesting that cannabis has weak recommendations and actually should be considered as a third-line treatment option. Some of the earlier systematic reviews found that there was some efficacy for pain, nausea related to chemotherapy, but the issue is that not a lot of older adults are included in these trials. So it's hard to extract the current evidence and apply it to our older population, only because the number of older adults that are actually included in these trials is very few. We have some evidence to suggest that it can help with neuropathic pain, but inconsistent for other things like fibromyalgia, MSK pain. Multiple sclerosis, it depends if it's spasticity related. There is more evidence for that. And then in the 2018 systematic review, it showed a similar number needed to treat and number needed to harm to opioids and other pain relievers. So this is a recent guideline actually published by Jason Busey, who is the current medical director of the Michael G. DeGroote Research Cannabis Center. So this recent guideline is very interesting in the sense that they actually took the most recent 4 systematic reviews in conjunction with studies that were around patient values. So the current guidelines from the UK and as well as here suggest that we should not be really looking into cannabis as an alternative treatment. However, when Jason's group actually dissected those reviews, they found that they didn't necessarily incorporate patient values and other more qualitative studies. So this guideline was certainly very interesting. I would suggest for those of you for more information, definitely check it out. What they found was that it has a weak recommendation to offer a trial of non-inhaled medical cannabis or cannabinoids in addition to the standard care and management for people living with chronic cancer or non-cancer pain. And like I said, they combined a series of systematic reviews as well as patient values and preferences. The recommendation was considered weak because of the close balance between benefits and harms of medical cannabis for chronic pain. However, they did place a higher value on small to very small improvements in self-reported pain in intensity, physical functioning, and sleep quality. So here you could see the way it's very well illustrated, this guideline, and they basically tell you the potential benefits that favor cannabis and the areas where it showed some improvement was reduction in pain, improved physical function, as well as sleep. And for CBD specifically, there have been trials since the 2000s involving CBD for treatment of chronic pain, and they've shown effects ranging from placebo equivalent to highly effective. There's also some evidence to suggest that CBD is effective for multiple sclerosis pain. And then in our CKD and kidney transplant population, there are more and more people that are gravitating towards cannabis, especially CBD, just because they cannot necessarily tolerate more stronger pain medications, and found that it can be effective topically for peripheral neuropathy. So for sleep, evidence is also mixed. Most of the evidence prior to this most recent guideline was basically suggestive of mixed results, that it may help with the sleep onset, but you have to be careful about tolerance, just like any other sleep aid. There is some interesting data about REM sleep disorder. So those people with Lewy body dementia or any other type of disorders that would have REM sleep disorder, CBD can be effective in reducing nightmares as well as for PTSD. So going back to the Jason's review, it did show that there is some small amount of evidence that the use of cannabis or cannabinoids can result in a small increase in proportion of patients experiencing improved sleep quality. So looking at cannabis and dementia, this is an interesting field because I have been now consulted on several occasions for cannabinoid use in the nursing home. And so a lot of family members, caregivers are actually reaching out because they want to look into avoiding antipsychotic use and looking into using agents like plant-based cannabis as well as like nabalone. So looking at the evidence for it, we found that the 2018 trial coming out of Sunnybrook did actually show some improvement in agitation, cognition, nutrition, and behavioral scores using nabalone doses between 1 to 2 milligrams compared to placebo. Earlier studies looking at plant-based cannabis showed some efficacy of the oils to help reduce behaviors. This is basically all of the trials that look at nabalone and dementia. And you could see that there are several trials that did show improved agitation, less resistance to care, improved psychomotor agitation. And so even with reduction of the scores that measure behaviors as well. However, if we look at this 2022 systematic review, it looked at the safety of agents such as nabalone and showed that the most commonly adverse effect to be felt is sedation. And so even if we go back to the nabalone trial out of Sunnybrook, they found that the doses that were closer to 2 milligrams resulted in more sedation. And so there certainly would be less resistance to care if the patient is more sedated. So it's important to understand that sedation is a significant adverse effect, which is similar to the other agents that are currently being used for dementia and agitation. Other indications include anxiety, appetite, and Parkinson's disease. With anxiety, there is inconsistent evidence supporting its use, although there are more studies looking at higher dose CBD preparations to help with reducing anxiety. And there is promising results. There was a recent poster presentation out of Dalhousie that looked at expectancy and CBD. So patients that received CBD, they had this expectancy to have a reduced anxiety response. So they were presented with 2 stressors. And after they knew that they received the CBD, when presented with the second stressor, they were certainly less anxious. So there is, like I said, it's controversial and inconsistent, but there is more promising evidence for anxiety-specific results with CBD use. Appetite, original studies were not well powered, did not support its use. They are looking at dronabinol for appetite increase. Generally, what we find is that it may result in a brief increase in appetite, but not necessarily increase caloric intake or weight gain. With Parkinson's disease, generally, there is a lack of evidence for cannabis use for Parkinson's-related symptoms. Some evidence for CBD for dyskinesias. In my clinical practice, I would say I've not really seen any effect with cannabis use to help Parkinson's related symptoms. Although if you were to Google it or YouTube it, you would, find a mountain of case reports and anecdotal data to suggest its use. So there are some common misconceptions. And so when I first encountered this cannabis space, I would often have patients come in asking about CBD that comes from hemp. and versus CBD that is available at a dispensary. Because as you know, CBD that can be obtained from a hemp product is available at a health food store. And we'll go through, like, what is the difference between that? And then is there such a thing as cannabis dependence and withdrawal? So with hemp oil, the CBD content is significantly less than the CBD that is found in a plant-based. So if you're if you're comparing the content, it's anywhere between 3% compared to a CBD product can have up to 20 to 25%, or 25 milligrams per milliliter of CBD product. It's the way the CBD is also extracted is also different in the sense that there's a crystallization method. So when you're taking CBD from the hemp product, you might be reducing its content when you're actually extracting the CBD from it. With dependence and withdrawal, we now, with the growing amount of evidence, we certainly do know that their tolerance and dependence can occur with cannabis use. We don't have as much evidence or long-term data on the dependence on CBD. However, I suspect that it's related because of the mechanism of action is less clear. Heavy cannabis use can follow a similar path to other drugs of abuse that cause blunting of dopamine release. Withdrawal, it depends on how long you've been using the product. So people that are using more THC-based products, if they're using it chronically daily for several years, often what we can find is that it can take about 3 to 4 weeks for it to really, completely clear. The average half-life of a THC-based strain is at least 3 to 4 days. And so there was a patient that actually, presented that she was delirious. Delirium was treated, it improved, and then she became delirious again. They did the whole delirium workup. It was negative, couldn't find any new reasons. But then the family did disclose that, she hasn't been getting her cannabis oil, and could that be, could she be going into withdrawal? So it's definitely possible. It's the science is not clear on when the withdrawal period actually happens, and if it necessarily occurs with CBD products. So contraindications, it really should not be used in any active ischemic heart disease or psychosis, although we are seeing CBD predominant strains being used in these for psychosis at least. If there is a low blood pressure to begin with, it can especially THC products may lower blood pressure as much as 40 points. So it's important to monitor blood pressure. THC products can also precipitate unstable arrhythmias. So those with atrial fibrillation or unstable INRs that are on warfarin products, there is potential for interaction as well. So even though it's considered a natural product, it does certainly have adverse effects. And the most important adverse effects are known as the 3Ds, so dry mouth, dizziness, and drowsiness. Change in appetite and weight loss are certainly possible. And I found that to be true with CBD-based products, where I have seen that the appetite has actually decreased. There's more psychoactivity with THC products, perceptual alternations such as with depth perception, especially with THC, headache and changes in bowel habits, short-term memory and attention impairment. Usually this is transient and with higher THC products. And palpitations and an increase in heart rate by 20 to 50%, as well as postural hypotension. So there are drug interactions with both CBD and THC. I mentioned CBD here because we have a little bit more concrete data about CBD's mechanism as it being a potent inhibitor of the CYP3A4 as well as CYP2D6, and thereby may increase serum concentrations of the following medications. So it's important to understand that if patients already have limitations in drug metabolism or clearance, such as those with chronic kidney disease, it's very important to be mindful that CBD may have interactions with several medications. So we'll briefly go through a clinical case. Mr. Payne is an 84-year-old gentleman living in the community. He's got history of chronic back pain, and he underwent a laminectomy in 2018. He's on multiple pain medications, including both long-acting and short-acting hydromorphone. He takes duloxetine, gabapentin, and nortriptyline. So despite this regimen, his pain is not controlled. He's been to the emergency room 3 times since his laminectomy for falls, and or most of the time it was for early medication refills. He has heard that medical marijuana can help his pain and even help him get off his pain medications, and thus the referral was sent. So when we looked at this case, we considered the different routes of administration. And at that time, it was shortly after his laminectomy. And so there wasn't very many formulations of the topical and spray weren't out then. And so we decided to go with a CBD predominant oil. So the CBD oil was prescribed. The dosing instructions were provided as such, where we gave him 0.2 milliliters to be placed on his tongue or mixed in with food of his choice. And we basically gave him a regimen to continue that for 2 days and then gradually increase by 0.1 until he gets to an effective dose. Now, it's important that you're giving these instructions either to the caregiver or if the patient is cognitively intact, because if they've got cognitive impairment, they certainly will not be able to understand these instructions. We told him not to exceed 1 milliliter, and eventually, if it was considered effective, then we can consider dividing the doses so that, if he's finding some relief with, 0.5 milliliters, but that causes a little bit of sedation, then we will dose that in the evening, whereas he can take a smaller dose in the morning that may not cause sedation, but may take that edge off the pain. So 6 weeks later, and that's usually, it's about 6 to 8 weeks later that I usually do a follow-up. And then he reported using 0.3 milliliters in the morning, followed by 0.6 at bedtime. He did report improvement in pain symptoms and sleep quality. He had no recent falls. More importantly, no recurrent visits to the emergency room. He did report dry mouth as a side effect. However, he was taking other medications that can also cause dry mouth as well. So at his first follow-up, we were able to get him off the short-acting hydromorphone altogether and slightly reduce the long-acting. Now, keep in mind that you may not be able to reduce medications at all. And sometimes the cannabis will just be more synergistic and will help maintain pain control without having the need to increase their existing regimen of medications. So where can you get more information? There are guidelines that are available. The cannabis use disorder among older adults is a 2020 guideline that not only looks at cannabis use, but looks at benzodiazepines, alcohol, and for cannabis specifically, it basically suggests that the evidence for cannabis use in older adults is quite weak, doesn't have enough trials that have older adults included in them. There is such a thing as, hyperemesis syndrome. Although we're not seeing it as commonly in older adults, maybe it's because more CBD products are being prescribed than THC. And generally speaking, we see, hyperemesis syndrome in younger folks that are using THC products in higher doses more chronically. The Michael G. DeGroote Center for Medicinal Cannabis also has several e-learning modules that can be accessed as well, that can help go through some of the actual pathophysiology of cannabis, looking at the endocannabinoid system. The RX Files also has a section on cannabis. It goes through plant-based cannabis as well as nabalone as well, and looking at the evidence. So that is a resource as well if you have the RX Files on your phone. And then these modules are actually new. They just came out this spring, developed for physicians, nurse practitioners, healthcare providers, and healthcare students. It looks at things that like what is the current evidence, prescribing. It actually goes through like how you should be speaking to patients about cannabis, conversations, discussions. So I would encourage for those who want to learn more to visit some of these modules, because they're actually pretty interactive and may provide supplemental knowledge as well. So we are, in terms of concluding, keep in mind that most of the evidence surrounding cannabis for pain management, as well as other geriatric syndromes, is low quality, largely cross-sectional, anecdotal based. We still don't know whether certain types of cannabinoids are superior to others. What are the optimal doses, the impact of accessibility and cost? We do know that the fastest growing demographic of cannabis users are older adults. And thus, there may be a role for cannabis for pain management, and can be explored further in this patient population. We know that more studies are certainly coming out. I know from McMaster, there's going to be a study looking at cannabis use for knee replacement and follow-up for pain control. And so the studies are definitely rolling out, but there's definitely been a lot of barriers to kind of achieving good quality evidence. So it's important that we start to research more and have good quality trials, and to really understand the effects of cannabis. So thank you.
Thank you very much, Dr. Sidhu, for this overview of a topic that not many of us know about, so it's really helpful. For those who wants to bring up questions, please write it in the Q&A section. You can write a comment in the chat if you want, or if you want me to bring you in to ask your question in person, please raise your hand. This question from Dr. Gernstein around the standardization of preparations that are available out there, and is the source of the cannabis equivalent to another at the same dose?
So standardization of the dose is actually probably one of the most difficult things to achieve. So if you want to keep dosing standard, you generally want to stick with one licensed producer that produces the same product. And then, just stick with the same strain. So if you're going with one LP that really produces a strain that's like high in CBD, such as like a 1 to 20 preparation, where 1 being the amount of THC and 20 being the CBD, you want to standardize the dose and start low and go up to a maximum dose in order to keep it more standard. But it's really patient specific, because certain patients will respond to different strain types. So to answer your question, there's a lot of lack of standardization in terms of dosing.
I had in my mind a question, which is a follow-up from Dr. Gernstein's question. It's related to, we do have the medical marijuana manufacturers, which is a licensed one, and then we have the licensed distributors, and then we have the corner stores at times. So in terms of product between the two licensed, a licensed medical producer and a licensed distributor, do you is there a difference in prices? Do you tell your patients just either one would work for you? Because it's all patients are paying from pocket right now. This is uncapped medication.
Yeah. So the licensed producers that are specifically manufacturing for medical use and medical grade, those products are often not available for distribution to the retail side. And you generally find those products to be very high in CBD with virtually like non-existent THC. When you extract the oil from the plant, there's always going to be a little bit of THC, but now with the technology and how it's evolving, they're able to produce strains that have virtually like, negligible amounts of THC. And so those are really being considered for medical grade use. Whereas the products that you'll see available at dispensaries, the Ontario Cannabis Store, you'll have a combination of CBD and THC, but those CBD products may have a little bit more THC compared to the medical grade products. And patients will try like those products as well. I just saw a patient last week that, obtained it from the Ontario Cannabis Store, and he was taking a CBD predominant strain from the retail side. And so we just have to like, educate patients on what the concentrations actually mean in terms of how much THC to CBD there are.
Excellent. Thanks, Mona. This is a question from Dr. Dorsami asking about the mechanism of arrhythmia and hypotension in cannabis users. And is this sympathetic activation and why the hypotension?
So it's THC products that we know that are doing it, and I believe that it's related to once it's acting on that type of receptor, and not everybody. So it's interesting because not everybody will necessarily have this effect. So if it's a clear mechanism of action, it should happen more commonly, but it's actually very uncommon. I do mention it in every presentation, but what we're actually seeing is that if you're using high dose THC in chronic quantities, you can have more of these side effects. But if you're using lower quantities of THC in smaller amounts, you're not necessarily seeing these side effects. But I'm uncertain as to the exact like mechanism of action because we don't see it happening all the time, and we really are seeing it with higher doses.
Excellent. Another question from Dr. Gernstein. Any evidence of depression as an AU with some of the preparation?
Yeah, so I find that it's indirect. So it's if it helps sleep, sleep can help with perception of pain, can help with perception, of energy, and you're feeling better the next day, and therefore mood improves. So we see this, kind of this like cyclic pattern of cannabis use in improving mood symptoms. We're seeing CBD can help with reduction of anxiety. However, the evidence for depression is actually very, very inconsistent and weak on whether it helps at all.
Okay. I have a question about the acceptance of use of cannabis in the elderly. Are you most of your referrals are coming from the patient? Are you bringing it up as a route or a method for managing their pain, or are they getting referrals from their family doctors? What is the general acceptance out there, and how we can change if there's an ongoing bias towards this treatment that sounds like it's helping some patients?
Yes, certainly. The most of the referrals that I receive are from caregivers that are requesting their family doctor to reach out, or the family doctor themselves that are, saying that I don't know enough information, but I can refer to someone that does have a little bit more experience with this. So I see both. I certainly do not bring it up unless, this is unless it's already known to me. So if it's in their social history that they're already using cannabis products, or it's on their medication list, or they bring it with them, then certainly I will bring it up and I will use that opportunity for more education. But in my practice at this time, I'm not bringing it up as a new treatment for patients. Only because, the evidence is still not completely there yet, and I am a little bit more on the conservative side on, openly prescribing without having the evidence there.
Thank you, Mona. I'm not seeing any other questions, or oops, there's one more. Dr. Carnu, why? I'm not sure. Document. You want to read the question, Mona? I'm not sure what Dr. Carnu is referring to.
What type of documentation is needed and how to chart use and explore if this is for them? Very good question. So there is a medical document that is required. So this is somewhat equivalent. We don't like to say it's a prescription, but it's basically the amount of product that they are allowed to order on a monthly basis. So you go through the licensed producer and you print out their medical document. You have to provide your information, the patient's demographic information, and then how much product that they're able to order. So the product ordering is in terms of grams. So you generally order anywhere between it's 1 gram per day, which equates to 30 grams per month. That means that they can order anywhere between 1 to 3 bottles of the oil. And so if you want to limit how much they can order, then you reduce the amount of grams that they can consume. So you could say 15 grams per month is the total amount, and that equates to maybe 1 or 2 bottles of the oil. There's a lot of questions that usually are asked about how to convert the grams to the milliliters, and it depends on the manufacturer and the strain type. So what I generally recommend is you start low regardless of the product that you start with. So you start with 0.1 milliliters if you're using the oil, or if you're using the capsule, you start with 1 capsule and gradually work your way up. That medical document is faxed to the licensed producer, and then you ask the patient to register with the licensed producer. So it's a 2-step process. You complete the medical document, they complete the registration, then you're able to order, and then you're able to faxing it, and then they're able to order the product themselves. You tell them what to order, and you provide additional dosing instructions. So there is a lot of paperwork and a process that is involved.
Great. Thank you again, Dr. Sidhu. Not seeing any more questions. Well, looks like I'm going to give people a few minutes back this morning, and I know that you need them as well. So thank you very much for this comprehensive overview, and it instigates a lot of thinking about the use of cannabis in the elderly. So greatly appreciated, and thank you, and wish everyone a good rest of the day.
Thank you. Yes. Have a great day, everyone.